Dear colleagues, I'm Dr. Taner Yılmaz from Hacettepe University Hospital, Ankara, Turkey. I'd like to talk to you about cordectomy for colorectal cancer. European Laryngological Society has a classification for cordectomy. Type 1 cordectomy is subepithelial cordectomy, in which case we remove the mucosa, epithelium only, which is the case for premalignant lesions, leukoplakia, erythroplakia, or carcinoma in situ, microinvasive ones. Type 2 is subligamental cordectomy, where you remove the vocal ligament. Type 3 is transmuscular cordectomy. You cut through the vocalis muscle. Type 4, you go down to the thyroid cartilage, and you go underneath the perichondrium to remove the cancer. This total cordectomy. Type 5 is extended cordectomy. 5A, if you pass from one vocal fold to the other one, it's 5A. If you remove arytenoid, it's 5B. If you remove false vocal fold, it's 5C. If you remove subglottic mucosa, it's 5D. If the lesion involves anterior commissure, then you do type 6. Now let's see a patient with leukoplakia. This patient has two leukoplakias on both vocal folds, and mucosal wave is intact, so it's not malignant. So we will remove them as a biopsy procedure and also prevent conversion to cancer. Before excision, I inject adrenaline solution to both vocal folds. It makes dissection easy, and it elevates the epithelium from vocal ligament, as you see. This is type 1 cordectomy, just remove those mucosa. One is excised, now the other one is being excised subepithelially. And you can leave it like this, or you can suture, which I did. Now this lesion, now this is the adrenaline injection below the epithelium. This lesion looks like a cancer, so I will remove the lesion for pathology, for biopsy purposes. I will do type 1 cordectomy. It came out to be a cancer. Then I performed type 2 cordectomy to the same area. You're seeing type 1 cordectomy right now. The adrenaline injection makes the dissection much easier, less bleeding, and elevates the epithelium from the underlying vocal ligament. If it can't, you can be sure that there is an invasion to the vocal ligament. Lesion is out. This is type 1 cordectomy. Vocal ligament is intact. The patient with type stage 1A colorectal cancer on the left side with no mucosal wave formation. I will do type 2 cordectomy on him. Here you have to go below vocal ligament, between the vocalis muscle and vocal ligament. I'm using thermal dioxide laser, 5 or 10 watts. As I go anteriorly, I will reach the thyroid cartilage. Reach the thyroid cartilage. I will do anterior commissure dissection with scissors. And the lesion is out. A larger lesion on the right vocal fold, again, stage 1A. One wave on the right vocal fold. Now, this will be a type 3 cordectomy, transmuscular one. I will go outside the tumor without facing the tumor, go anteriorly through the muscle. I perform my incision with anterior concha well, and I reach the thyroid cartilage. I connect both incisions and remove the vocal fold. With the anterior concha, I usually prefer sharp dissection, scissors, knife, or laser. Try to see clean cartilage without tumor invasion. As you see, I went down to the lower border of the thyroid cartilage. It's out. This looks like a smaller tumor, but actually it's a more invasive tumor. It may invade into the right ventricle. So I will be doing type 5 cordectomy, type 4 and type 5 together. See, ventricle, lateral wall of the laryngeal ventricle is involved. Incision, and then go deeper, reach the thyroid cartilage. And I will go anteriorly. For the anterior commissure. This is type 5C together with type 5A. Again, cartilage is reached, and I will be dissecting anteriorly toward the anterior commissure. You see, this is the Broyles ligament being cut with scissors. And tumor is out. I fix the tumor with pins for pathologic orientation. See, all tumor margins are free of cancer. A lesion of the anterior commissure is seen uncommonly. Here, the lesion starts at the anterior commissure, goes toward the subglotis, and invades the left vocal fold as well. So I will be making wider incision on the left side, smaller incision on the right side, and then go deeper to reach the cartilage. When you reach the cartilage, I will do sharp dissection with knife, straight knife, or curved knife. Then reach the anterior commissure. Now I reach the Broyles ligament. I will cut it here with laser and go inferiorly. As I reached the lower border of the thyroid cartilage, you can see now I'm dissecting the cricothyroid membrane. The tumor, as the tumor invades subglottis, I will reach the superior border of the cricoid cartilage, then cut the tumor and remove it. You see cricothyroid membrane dissection. And fix the lesion with pins for pathologic orientation. Again, the tumor, the surgical margins are free of tumor, as you can see. Now, this video is 1 month post-op. The healing still continues. There's a membrane formation, but the larynx looks very good, in good shape. Healing still continues. Membrane indicates granulation tissue. Thank you very much for your attention.